So welcome everyone to the Society of Thoracic Surgeons. Today we have our General Thoracic Surgery Database monthly webinar. Today is Wednesday, March the 13th of 2024. So hope everyone's having a great week so far. Agenda today, I just have a few brief STS updates, and then I'm going to turn things over to Ruth, who's going to do a little review on lung cancer clinical stage or lung cancer staging. So we'll turn things over to her, and then we'll finish up per usual with our Q&A. So if you do have questions, please be sure to put those into the Q&A. We also have the raise hand function enabled. So if you'd just like to ask your question, feel free to do so. Just raise your hand. We'll unmute you and just ensure that your microphone is enabled on your end. On the call with me today, we have myself. We have from the STS side, we have Emily Conrad, Addie Dolan. We have Banu, and we have from our STS consultant, we have Ruth Raleigh, and then we also have Katie joining us from the core group. So thank you everyone for being on today. I appreciate you guys being here. All right, let's go ahead and jump into my STS updates. If I can get my slide to advance here, that would be helpful. Let's see here. If I click the right button, that usually helps. All right, so STS updates. The February training manual was posted and is available. Our March training manual will be posted by the end of this week, as well as that supplemental neoadjuvant training manual will be posted by the end of this week as well. Dr. Cedar wanted to review that before I got it posted. So as soon as he gives me the go-ahead, that will be posted. And again, I do plan to have that out by the end of this week. We had some additional clarifications to make based on some questions that were submitted earlier this month. So I definitely wanted to get those clarifications in there before it got posted. GTSD public reporting. Our public reporting website was updated in January, and that did include results from the fall 23 harvest analysis. Our next website refresh is scheduled for January of 2025, and that will include results from the fall 24 harvest analysis. As you are, I'm sure, very aware, the spring 24 harvest has officially closed, and that did close on Friday, March the 8th at 11:59 p.m. Eastern Time. The snapshot for that analysis data set was taken shortly thereafter at 11:59 p.m. Eastern Time on Friday evening. That spring 24 harvest analysis does include those surgery dates of January 1, 2021 through 12/31 of 2023. And that report posting will be available late spring, early summer. As soon as I get a more definitive date, I will keep you guys posted on when that will be available. But again, I'll provide you with that information as soon as I have it. The fall 24 harvest close is scheduled for September 6th. So go ahead and mark those calendars. And again, just do encourage you to submit that data early and often. And definitely plan to submit your final file a couple of days prior to that harvest close date. So just be sure you plan accordingly, and just in case anything does go wrong and you're submitting that last day, it happens every time. So again, just make sure you get that final file in at least a day or two prior to that very last date for harvest close. The opt-out for that fall 24 harvest is September the 10th. And that is all. Oh, I'm sorry. Nope. I'm sorry. I lied. I'm trying to skip right on over to you, Ruth. Just get right on over there. Again, just the harvest schedule in case anyone needs that, wants to print it out, will be included in the slide deck and posted on the STS website. 2024 AQO Data Managers Meeting. Again, as you know, will be held in Nashville, Tennessee this year. We're looking forward to being back live and in person. AQO is scheduled for September 11th through the 13th, with the thoracic session being held on Wednesday, September the 11th. And hot off the press, we will be at the Lowe's Nashville Hotel at Vanderbilt Plaza. So we're excited to finally announce where the conference will be held. And again, it'll be at the Lowe's Nashville Hotel at Vanderbilt Plaza, close to Music Row, downtown Nashville. So we're looking forward to that. Please know that STS is now accepting proposals for the 60-minute sessions to be presented at the conference. I've included a link to our STS AQO session proposal form here. The AQO planning committee will review all proposals and select those that we think will be a good fit and appropriate for this year's AQO program. I don't know, Emily, did you want to provide any more information or any more info on the session proposals that's new this year?
Yeah, so on the proposal form, you'll find a slot for like your idea for a topic. If you have any speakers that you think would be good to speak on a topic, or someone new, but also very knowledgeable about the STS national database, would probably be someone good to provide a talk. On the form, you'll just enter your contact information, the topic presentation, what type of format you would like to see, and then a session description, learning objectives if you can come up with some, and then the speaker name. You can also submit it without a speaker name, without the learning objectives. If you don't know who you would want to speak, that's fine too. But any ideas are welcome and encouraged. And we will meet with the planning committee in the late April. So this session proposal will be due on Friday, April the 19th. So you have about a month to submit if you would like to.
Great. Thank you, Emily. This was a great idea for this year. So we're excited about it. And hopefully, we get some good feedback from you guys and get some proposals from the data managers. We just want to make sure that we are providing the content that you all need the most. So just make this is your conference, so we want to make it beneficial and include presentations on what you guys are wanting and needing. So,
and then registration pricing will be posted probably in like early to mid-April. And then we will post the link to be able to register, like for your hotel, the block. We'll put that on our website as well. We just don't have that ready just yet. So more to come for that registration link and the housing link within like early spring.
Awesome. Brian had asked, and I don't know if you have this yet, Emily, or not, but do you happen to know when poster submission date is going to be?
So our goal is also to have that open in the early spring as well. More to come on that, but probably April, May.
Okay, perfect.
Yeah.
Thank you.
Yeah.
Awesome. Thanks so much, Emily.
Mm-hmm.
And so yeah, if you have any questions regarding AQO, just feel free to reach out to myself and or Emily. We can answer any questions that you may have. But as Emily said, we'll provide more info on pricing as soon as we have it. All right. So now I'm going to officially turn things over to Ruth for her presentation on staging.
Hi, everybody. I thought for this webinar, we would spend some time talking through lung cancer staging. I know that some people have tons of experience doing this, and this is going to be not the most exciting presentation, but some people are newer to the database and have asked lots and lots of questions about this. So I thought we would sort of go back to the basics on this one, and hopefully everybody will learn something. So what is lung cancer staging? Lung cancer staging is a way of describing where the lung cancer is located, if or where it has spread, and whether it's affecting other parts of the body. It's generally broken down into 3 parts: T, which stands for tumor, N for node, and M for metastasis. Lung cancer staging can be performed once or twice. So all patients with lung cancer are clinically staged. It's always performed, and it always occurs prior to any treatment being rendered, whatever that treatment will be. Pathological staging is only performed for the subset of lung cancer patients who end up having a therapeutic surgical treatment, and of course comes off your pathology report. And I hope that when we distribute these slides, that the links that I have put in all of these slides will be clickable for you. There is like little blue links at the bottom of a lot of these pages, which contain good resources for a lot more information if you're interested.
Yeah, I think they typically are. But if not,
Perfect.
if you want the links, you can reach out to me directly.
Awesome. Thanks, Ann.
Mhm.
You want to go to the next slide? Okay, so
Yes,
how is clinical staging data used? So essentially it's used by physicians to determine the best course of treatment for a patient. This includes things like eligibility for clinical trials, and then helps them sort of determine which standard treatment option is going to be right for the patient with this stage of disease. So us, being part of the Society of Thoracic Surgeons, really are looking at patients that fall into the first 3 buckets. It's patients who have a surgical resection in isolation, patients who have neoadjuvant, which is also known as induction therapy, followed by surgical resection, or patients who have a surgical resection that's followed by adjuvant chemotherapy and or radiation. There are, of course, many other treatment paths that patients can take, but all of those treatment paths are determined by the patient's clinical stage. Go to the next slide. How is clinical stage determined? So really, clinical staging is based on imaging results and biopsy results for the most part. So on the imaging side, we have CT scans, PET CT or PET scans, and then MRI data that we can review from imaging. And then on the biopsy side, of course, there's a whole host of different biopsy options, but patients have endobronchial ultrasound, mediastinoscopy, and I guess I should have listed Chamberlain procedures there as well. You can have VATS procedures that occur prior to the primary surgical resection. CT-guided core biopsies or fine needle aspirations will sometimes occur as part of clinical staging. Bronchoscopy that is not EBUS, so traditional bronchoscopy, navigational bronchoscopy, there's robotic bronchoscopy now. Sometimes these are branded and copyrighted and named in all sorts of different ways. And then thoracentesis as well will sometimes identify a patient, usually with late stage lung cancer, or it will rule out a late stage lung cancer based on thoracentesis results. I'm going to go to the next slide. When is clinical staging performed? So clinical staging, again, is determined that value is assigned prior to any treatment occurring. If a patient has repeat imaging studies performed that occur prior to any treatment, you would use the CT scan closest to the date of the first treatment to code the clinical T stage. So it will sometimes, well, we'll just keep going. There's an example. Gonna go to the next slide.
Yes. And we do have some polling coming up in these questions. So just so you're aware, sorry, I failed to mention that before we got started. So
Oh, sorry, I should have.
That's all right. My fault, Reed.
So this is the first question. So patient X had a CT scan of the chest on January 1st and on March 15th, and they had induction chemotherapy that began on April 1st. They had a CT of their chest on 5:30 after they completed their induction therapy and prior to their surgical resection. Which CT scan is used in determination of clinical T stage? A, January 1, B, March 15, C, May 30th, D, all of them, or E, none of them.
Can you see the polling, Ruth?
I can't actually.
Are you guys able to see the polling? I think Ruth and I.
Oh, there it is.
There
It just popped up. Yep.
Okay, cool. I was like, what's going on? All righty.
I can't see the results coming through, so let me know when the answering slows down.
Yeah, and Whitney has her hand raised too. So as soon as we, I assume it has to do with this question, perhaps. Oh nope, she took it away.
Okay.
Okay, we've got about 57%
Yep.
in.
Yeah.
We'll give it a couple more moments and then
Yeah.
end the poll.
Thanks, Emily. Emily's running the polls for us today. She's way better at this than I am.
I apologize. I was late.
No, you're good. I was still fumbling around. I'd probably still be fumbling around. I've got so many screens open.
All right, I'm gonna go ahead and end it. It looks like 65% have participated.
Yeah.
I'll share the results.
Perfect. So B is the correct answer. So this patient had multiple CT scans before they started any treatment. And so you're gonna take your clinical T stage from the CT scan that would be part of your clinical T stage evaluation is going to be the CT scan that is closest to the start of treatment. So that April 1st date. You wouldn't use the May 30th CT scan because treatment has already occurred and clinical staging happens before treatment starts.
Ruth, Nicole had a question. She's like, if all imaging is greater than 4 months, can we not use them?
Let me pull up the training manual again.
Oh, sorry.
No, it's okay.
We can come back to it if you.
Yeah, let's come back to it.
Yeah, come back
And then
to it.
we'll have
Sorry.
the training manual and I can make
Yep.
sure.
Yep.
If I need to add anything, I can, you know. Okay. The next, where is clinical stage documented? Clinical stage is usually documented in your surgeon's pre-op H&P, but can also be found in oncology or tumor board notes. Documentation of clinical stage in the EMR is a Commission on Cancer requirement, so it's usually there somewhere. You just have to find out where it is in your EMR. Clinical stage is never included on individual imaging reports. I've got a lot of data managers that have asked where in the imaging report they can find the clinical stage, and the radiologists really don't have a complete picture of the patient's pre-treatment stage from any single radiology study that occurs in isolation. And so you will never see a radiologist dictate a clinical stage into a radiology report, and that's not unusual if you're seeing that at your site. If your surgeon is not documenting clinical stage, I would discuss that with them. This is their data. They need to provide you with accurate information so that you can represent their work accurately. A lot of sites have templated notes that they use in their EMR, and clinical stage is one of the things that they will fill into that note so that their data managers have it easily available instead of having to put the pieces of the puzzle together. Go to the next slide. Question number 2. Patient X had a CT scan, PET CT scan, and EBIS. Clinical stage is not documented in any of these reports. Should you leave sequence 1810 clinical stage lung tumor blank? Yes, no, or not sure.
A little bit of everything here, Ruth.
Right. At about 60%, 65%. We'll close the poll here in a moment. I'm gonna go ahead and end it.
Thanks, Emily.
Okay, the correct answer for this one is B, no. So as I mentioned, clinical staging is really putting together all of the pieces of the puzzle. So you've got a CT scan, a PET scan, and an EBIS. You are unlikely to find the clinical stage documented in so many words in any of those individual reports because somebody has to put the pieces of the puzzle together to come up with the clinical stage for the patient. That person should be either your surgeon or your oncologist. If they aren't doing that work and putting it on paper, they're doing the work. The question is whether they're putting it on paper. If they aren't putting that on paper for you to find, then have that conversation with them. But I would not expect for you to see a documented clinical stage in a CT scan, a PET CT scan, or an EBIS report, just because that's only one piece of the puzzle, and that stage doesn't really come from those sources as an individual source. Okay, this next slide has a beautiful graphic that Katie recently shared with the core group, and I think it's really helpful when thinking about clinical T stage and in a lot of other spaces as well. But the first step is to determine what type of a lesion that you have. So if you look at your CT report, it's going to tell you whether you have a solid, a subsolid, or a cystic lesion. Subsolid lesions are further broken down into part solid, or sometimes called semi-solid lesions, and then the pure ground glass lesions. If you click on the little link in this one, it'll give you some more information about that. So that's the first part of your analysis. Once you understand what kind of a tumor you have, the size of the primary tumor, and if it has grown into adjacent structures, is really the information that you need for determining clinical T stage for solid and cystic lesions. So this graphic, which is taken from the training manual, I believe this graphic isn't, no, it might not be in the training manual. If it is not, I'll add a link to this, Leanne, just in case anybody wants it. It's widely available on the web. But you need to know the size of your lesion, and then you'll see where it talks about, for example, under T2. So if the tumor is invading the visceral pleura, the main bronchus, or there's atelectasis to the hilum, then any tumor that involves any of those things becomes a T2 lesion, and you're sort of disregarding the size, similar with the other or invadings down in the T3, T4 section. I'm going to go to the next slide. A word on cystic lung cancer, because this recently came up. Cystic nodules look very different from a traditional nodule. There's a picture of one on the right-hand side of the slide. You can see that the outside of the lung cancer is this sort of solid wall, but the entire middle is just empty blank space. These are measured similarly to the way that solid nodules are measured from edge to edge. There's conversation about whether this is truly the most reliable way to measure these, and it's an area that they're going to further investigate in the future. But for now, this is the way that it's done. It's thought that it might overestimate the total tumor burden and not quite accurately reflect the patient's prognosis, but it is what it is for now. So cystic lesions are measured edge to edge, just like a solid nodule, which would also impact the data that you abstract for sequence 1800, which is nodule size. Okay, now we're going to take a deeper dive into the T3 and T4 lesions, specifically where it talks about separate tumor nodules in the same lobe for T3 lesions. And then in T4, it says tumor nodules in a different ipsilateral lobe. I'm going to click to the next slide. So you are going to need to use your biopsy data and notes to determine if any nodules are presumed benign when you have more than one nodule. Solid nodules that have been stable on imaging studies for more than 2 years are generally considered benign. Subsolid nodules that have been stable on imaging for 5 to 10 years, depending on their characteristics, are also generally considered benign. Whenever you have more than one lesion, you need to consider the possibility that your patient has synchronous primary disease, meaning that they have more than one early stage lung cancer occurring at the same time versus clinical T3 or clinical T4 disease. This is super nuanced, and if it's not clear from the notes in your EMR, you're just going to have to ask your surgeon. Unfortunately, if you submit these as FAQs, it's really hard for me to sort of put together the pieces of the puzzle without having complete access to your EMR. You've probably already tried to do this using everything in your EMR. And you know, truly, if you can't figure it out, I'm unlikely to be able to figure it out as well. So you really just are going to have to go back to your surgeons when you've got more than one nodule and it's not clear whether they believe these to be synchronous primary or whether they think it's a T3 or T4 lesion. These are just some examples of synchronous primary adenocarcinomas. I thought that the pictures were helpful. You can see that you can have more than one primary adenocarcinoma, and they can be 2 ground glass nodules that are pure ground glass. They can be mixed density with a pure ground glass. They can be 2 mixed density lesions. They can be a ground glass lesion with a solid nodule. You can have 2 solid nodules. So knowing the density of your lesion doesn't necessarily mean that you can rule out it doesn't define, I guess, whether you've got synchronous primary disease or whether you've got metastatic disease. So really, you're gonna just have to go back to your surgeons and have them clarify if they haven't already clarified for you in notes. Okay, now we're gonna go and focus on how you would determine the clinical T stage for the group in the middle here, which is the subsolid nodule set. If you want to go to the next slide, this graphic is included in the training manual. The link is also on the training manual as well. I think what's tough about the way that this exists in the training manual, I believe still currently, is that the top part of this graph is separated from the sort of the fine print of this graph by a page break. So I just want to make sure that everybody's aware. The top portion of this graph, the sort of light yellow portion is, you can see the little C in front of the T. The intent is that this can be used for clinical T staging. And then you'll see if you sort of go to the first, like if you do solid part less than or equal to 0.5 centimeters, you can see there's like a little teeny tiny cross next to that one. And if you go one down, there's like a double cross, and then there's different sort of designations that exist with this chart. If you want to go to the next slide, Leanne. This is the fine print, and this fine print is in the training manual. And so most of the questions that I get about what the clinical stage for a mixed density lesion should be, I can answer by digging through these cliff notes here. Quite often it's because the total overall size of the mixed density lesion is greater than, I think, 3 centimeters. You'd have to go back to the previous slide. I don't have it memorized, but yeah, if you've got a total tumor size greater than 3 centimeters, you're going to have to reference the cliff notes to understand what to do. And it's all there. It's just teeny tiny. So read through this if you've got any questions on how to clinically stage a mixed density lesion. Okay, clinical end stage. So clinical end stage is often obtained from CT data, PET data, mediastinoscopy, EBUS, and then any other bronchoscopic biopsy of mediastinal lymph nodes. The training manual indicates that all lymph nodes greater than 1 centimeter on PET or PET CT are considered positive. All PET positive nodes are considered positive. However, pathology results will always overrule radiological findings. You want to go to the next slide. So this is a question. A PET CT scan obtained on January 15th, 2023 is positive for lymph node metastasis only at station 10. An EBUS is performed on January 25th, and the pathology for station 10 returns as negative. How would you code sequence 1820 clinical stage lung N, which is clinical end stage?
Did the poll launch for you guys?
Yeah, the poll's not showing up on this one, sorry.
Yeah, it's not. I hit launch, but it's like grayed out and it's not actually launching. We might have to just give it a little think here for you guys.
Yeah, I think you may not have closed out the window from the previous one, Emily,
Oh,
from the
okay.
previous question.
Okay.
I think that's what happens.
Okay.
And then you can launch the next one.
Okay.
Oh, sorry, I was talking to myself. I was on mute. I didn't realize it.
Is this one not going to launch?
Okay, I shared the results of the last one.
Yeah, you'll have to close that out.
Okay. I'm sorry, guys.
No, you're fine.
I don't know. Okay. I don't think it's gonna work. I don't know how to like close it out.
Let me see if I can do it. Hold on. Do I have access to polling? Sorry, guys. Polls. Hold on. Let me see. Okay, March. Stop sharing. Let me try this. Sorry, guys. Hold, please.
I'll X out of it.
All right. Do you want me to see if I can try and launch it, Emily?
Sure. Yeah. Sorry.
Okay. No, you're good. I think.
Perfect.
There it
All right,
goes.
it's showing. Sorry.
Okay, good. I know it's all right. it's wonky sometimes. All right. So we got about 50% answering, Ruth. 80, let's see here. Looks like majority have gotten this one. Give it just a couple more seconds. All right. I'll go ahead and end this one and share results. All right. There you go, Ruth.
Perfect. B and 0. So recall, the pathology results will always overrule anything that you see in imaging if a biopsy of the same station occurs. So if you got positive station 10 lymph nodes on PET, but they take a biopsy and they come back as negative, then you've got a negative station 10. So the clinically stage is N0. Okay, next slide. Another question. Patient NB had a single EBIS positive station 7 lymph node on 3/15. They subsequently had neoadjuvant immunotherapy. The most recent PET shows no positive lymph nodes. How would you code sequence 1820 clinical stage lung N? N1, N2, N3, N0, I'm not sure.
Alrighty.
How's it looking, Emily?
Yeah, it looks like about 50% has filled it out. So we'll go ahead and end the poll.
All right. And the correct answer is B.
So remember that your clinical staging information has to come back prior to any treatment being performed. So the PET scan that happens after the neoadjuvant immunotherapy that has no positive lymph nodes is lovely. That means the patient had a great response to treatment, but that doesn't change the patient's initial clinical stage. I'm going to go to the next slide.
Yes, ma'am.
Another question, my surgeon's pre-op H&P says the patient's clinical stage is CT2A, CN0, CM0, but they have 2 lymph nodes that are larger than 1 centimeter on CT and PET positive. I can't find a biopsy report that indicates these lymph nodes were negative for cancer. What do I do? Ask my surgeon, submit an FAQ, code positive lymph nodes, log off for the day, and binge Netflix.
I'm letter D, log off for the day. If I could respond, that would be my answer. I don't know.
Yeah.
Whoever answered that already, you're my people. There too. Got a little bit of everything here, Ruth.
Got about 60% that have filled out. So we'll go ahead and end the poll.
All right. And if I can find my mouse, I will advance the slide. And
I'm so happy to see that we have a lot of people that are going to go ask their surgeons. So if there's a discrepancy between what you believe the correct clinical stage is, particularly for nodal staging, but really for all things. If you believe there is a discrepancy between what your surgeon has documented as the clinical stage and what you believe the clinical stage should have been documented as, you should always go back to your surgeon and ask them to clarify their documentation and how they arrived at their conclusion. First of all, because you learned something, and secondly, because sometimes it could be just a documentation error and they can clean that up. You will see sometimes in your surgeon's notes that they document an overall clinical stage, which is based on a combination of T, N, and M. Your surgeon, it's not specific enough for you to parse a clinical T, N, and M out of this documentation unless you have other information. So for example, if your surgeon says like, overall, this patient appears to have a clinical stage of 2B, you don't really know whether your patient has a T1 lesion, a T2 lesion, a T3 lesion, and 0. So you would have to go back and either determine what the clinical stage is yourself and figure out how that fits into the overall clinical stage that your physician has documented, or ask them to help you determine what the clinical stage is, TM and MY is. Next slide. Clinical M stage, don't make any assumptions. You can't assume that every single patient that goes to surgery is a clinical M0. The overwhelming majority of patients are a clinical M0. But if you have brain imaging reports, you need to read them and make sure that there's no note of metastatic brain disease, although hopefully your surgeons would include that in their pre-op H&P. You should also look at your complete PET scan results if things are noted as potentially being metastatic disease. Again, hopefully your surgeons in their notes have indicated why they don't believe those to be metastatic lesions. You will sometimes see biopsies of strange things after PET reports, just as surgeons go through and rule out things and ensure that they are not metastatic disease. If something's noted to be positive, look for those workups, and if they're not there, ask your surgeons to confirm that your patient doesn't have clinical metastatic disease. It is not out of the question that a patient with clinical metastatic disease would be a good candidate for surgery. There are some patients with oligometastatic disease, which is a type of metastasis in which there are cancer cells from the original lung tumor that have gone to only 1 or 2 other places. And those patients can have treatment for just those 1 or 2 metastatic sites and still be good candidates for a therapeutic lung resection. And again, patients with metastasis to the contralateral lung, so the lung on the other side, are considered to have metastatic disease. So it's really important to understand whether your patients have synchronous primary disease versus metastatic disease, going back to that slide that occurred earlier in this presentation. A final word on clinical staging. Your surgeon has always at least mentally, clinically staged patients prior to elective therapeutic lung resections for lung cancer. Encourage them to document it in a place where you can find it. It will save everyone a lot of trouble if they do this, and you will have the most accurate data. It's their data. They should want it to be captured accurately, so encourage them to document it where you can find it. Clinical staging, if you end up having to do it yourself from imaging reports and test results, takes lots of practice. Don't get discouraged. Ask your surgeons to confirm that you're correctly. Oop, now I've got your email, Leanne Jones. And, ask your surgeons to confirm that you are correctly abstracting their cases every time when you're unsure. And if I had one more slide, it would say, ask your surgeon. That's all.
Thanks, Ruth. Sorry, but I was trying to pull up a question that I gotten earlier via email that I thought would be good. I didn't see it asked yet. So let's go ahead and tackle some of these questions. And I just have the next webinars listed here. So just be sure and mark your calendars accordingly. So let's move on with our questions. Let's tackle the question. Let's tackle Nicole's question. If all imaging is greater than 4 months, can we not use them?
So if all imaging is greater than 4 months, you cannot capture it in sequence Oh shoot, I had it pulled up. 1 second. It can't be captured in sequence 1620, which is clinical staging methods, but that's the only sequence for which it is noted that you can't use imaging greater than 4 months. So you would correctly record the patient's clinical stage based off of whatever data that you have available.
Okay, thank you. All right, Stephanie had a question. And it's about clinical staging being clinical T stage being documented. Let's see.
Oh, I saw her question. It's sort of a two-part question. So
Yeah,
what she's wanting to know essentially is if her surgeons haven't documented the clinical stage in the chart up until now, can she determine the clinical staging for these past cases, or should she leave it blank? And Stephanie, you should enter the clinical stage based on the information that you have available to you. So imaging reports, biopsy results. If at any point you're unsure that you've done it correctly, please ask your surgeon to confirm those clinical stages with you. Which I think is also Doreen's question. Can abstractors determine clinical stage? Yes, they can. It doesn't have to be documented by the provider. However, your surgeons want accurate data abstracted, and the easiest way for your surgeons to get what they want is to document it for you to find.
perfect. All right. Yes, I put so let's see here. Okay, let's go back up to, I can take the one about the GTSD user group call from the 28th. There was marketing had the incorrect time written down and included in the email blast, so that everyone logged on an hour prior to when it actually started. So that was the issue with that webinar, but the recording is, I believe it is posted and available out on the website. So you should be able to go back and review that, but that's what happened. So I apologize for that error. Let's see here. Okay, so Laura wanted to know if an FAQ got removed, and it had to do with DLCOVA.
Yeah. So yes,
Yeah.
Laura, that FAQ did get accidentally deleted, and I noticed it about I don't know, 2 or 3 weeks ago, I guess. So it's been added back in the March training manual that will get published. I've added it back in with the same date as the original date. It's unfortunate, and I'm sorry that got deleted. I apologize, but the guidance is the same. So I think probably the best thing to do, she asked for some additional education about PFTs. I'll include that in the next webinar, and we can highlight that sort of a series of FAQs related to DLCOVA and KCO, et cetera. I apologize about that.
Yeah, I hope that was, it could have been something that I did when I was PDFing it, so I'm sorry about that. Let's see here for the neoadjuvant. If no, we just talked to Dr. Cedar about this, Ruth, about if there's no PDL 1% or PDL percent.
Yeah, so unfortunately, right now, the way that the red cap form exists, it's for neoadjuvant therapy. If no PDL 1% was done available, what are you supposed to enter? We're actually adding an option to that sequence, which is PDL1 not tested, that you would be able to check. We don't want you to enter 0 because 0 implies that it was tested for and there was a 0% result. Unfortunately, when we add fields to the red cap, we have to publish a new link for the red cap. So there's actually a couple of fields that we're going to add to the red cap and put a new link out there again. So I apologize for the inconvenience on that, but that will be coming up shortly in the next couple of days.
Right. And just to clarify, when, unfortunately, like we said, when we do make those changes like that, there will be a new red cap link. The most current and up-to-date link will be included in that neoadjuvant training supplemental training manual. And also I will also have a link to the neoadjuvant training manual on the STS website. It'll be posted underneath the data resources under 521. It'll be posted right underneath the training the data collection resources, the DCF. There will be a link posted to the red cap form under that as well. let's see here, we had, Stephanie had questions about the slides. She wanted to know when the slide deck will be available for posting for download on the website. I'll send the recording and the slide deck over today, after this webinar, once I get the link. Marketing usually posts a slide deck, they'll typically have it posted tomorrow or maybe even later today. It just depends on Gabby's schedule and what she's got going on this afternoon. But I was just going to pull them up rather quickly if you just wanted to take a screenshot in the meantime. But I will send the slide deck over today and hopefully it should be posted tomorrow. The webinar recording should be posted by the end of the week, maybe first of next week. But here's the one on determining the type of lesion. If you wanted to take a screen grab, and then I'll put the other one up in just a second. Let's see here. All right, Ruth, our next question is, if a patient has multiple primary tumors, say T2A, T1A, M0, M0, do we capture the one with the highest staging, T2A, for pathology?
For pathological staging, I believe the directions are in the training manual, and it indicates that you are supposed to enter the data for the lesion that is most aggressive. So it's not based entirely on size. It's going to be based also on histology and grade in some cases. So you would have to look at sort of the total picture and determine which patient or which lesion is most aggressive. What we're trying to do is link that data back to patient survival data. So for example, if you have a smaller large cell neuroendocrine tumor, that tumor is more likely to impact survival than a larger adenocarcinoma. If you're not clear which one is more likely to or more aggressive or more likely to impact survival, you can always clarify that with your surgeon. But I believe that's the direction in the training manual as well.
Okay, next question. If a bronch is done twice within the same procedure, navigational and diagnostic, do I only code it once as navigational or twice?
I'm not sure specifically. It's quite, Anna, if you can clarify for me where you are talking about coding it once or twice.
Mary, which she had to join late, but you covered this, but can you restate, our data manager is allowed to calculate clinical staging if it is not done by the surgical or oncology team?
They are permitted to do so, yes. But ideally, your surgeons will document this for you so that they have the most accurate data possible. Because they have certainly done the work in their heads, Mary. Hopefully, they're just putting it down on paper for you to pick up.
All right, let's get down to Doreen's question. M-stage is not included in our pathology reports. Is typically what is submitted to pathology is not sufficient to determine distant metastasis. Should the field be left blank?
No, your pathological end stage, you're correct. It'll never be included on your pathology report unless your pathology report is an autopsy, I suppose, because you don't have samples of all the sites. So you're going to use information from your surgeon's notes and clinical staging workup to determine what should be entered as your pathological M. You wouldn't leave it blank.
All right, and Mary, my path reports rarely contain the R1, R0, et cetera. Okay to leave blank, or should I pursue this information?
Your pathology reports very likely contain information about your margins, which is really what that R1 and R0 relates to. If your pathology report is indicating that you have a positive margin, then you need to investigate that positive margin to determine whether it was grossly positive or microscopically positive, which is where you get that R1, R2 information. You don't specifically need R0, R1 as a term, I guess, but I'm betting that information is there. If you want to send me a couple of your pathology reports, I'm happy to look at them with you.
All right. If patient has trach after index procedure, do we count tracheostomy sequence 3820? and post-op procedure through new or existing incision 3670.
Yes, if your patient returned to the OR for a trach, you would capture both. And again, remember that complications are analyzed as all or none, so there's really no harm, I guess, or your site won't be penalized for capturing the same return to the OR in more than one bucket.
Great. Perfect. Thank you, Ruth. I was trying to get back to, let's see here, what was the question? I'm not, let's see, are there any additional questions coming in? Not seeing any. Oh, here we go. Anna, she doesn't have a mic. Sorry, that's all right. The op note stated a bronchoscopy was done twice within the same surgery. Once was done as electromagnetic navigation bronch, and the other as bronchoscopy with tattooing with transbronchial needle approach.
You can capture them separately in your procedure list. That's fine. There is a procedure code specific to navigational bronchoscopy.
And Elise Elise was stating some path reports will state results represent microscopic findings unless specifically noted otherwise, and this often refers to the margins. Then I had a question here, Ruth. Somebody had asked if a lung cancer resection case with pathology T0, N0, M0, no treatment prior, it won't be analyzed, but is it necessary to enter those types of cases at all? So as she was clarifying, patients that do receive neoadjuvant treatment prior to surgery for same disease. Oh no, this is a different question, I'm sorry, but for those cases that have a T0, N0, M0, she's asking if she enters those.
I didn't hear the beginning of the question. I don't think. Was it a pathological T0, N0,
Yes,
M0
yeah.
with no
T0.
treatment?
Yes, with no treatment prior.
That's atypical. If they want to send me the
Okay.
associated notes, I guess I'm not
Okay.
sure that the patient had lung cancer if they had
Okay.
treatment and also no tumor. I'm not sure what happened.
Okay, perfect. Sorry about that.
No, it's okay. Thanks.
All right, let's see. But there was another question from Anna. Did you answer that one already for?
Oh, she was looking for a CPT code for the tattooing.
Okay.
I don't know that offhand, Anna. I will see if there is one. I would have to search for it. I don't know it offhand.
Alrighty. Just in case, I will wait just another minute, see if there's any other questions that come in. But in the meantime, here is the contact information if you need to contact myself, or if you have questions related to your harvest analytical reports. If you have questions about submissions to IQVIA, access to the platform, please reach out to the help desk, stsdb_helpdesk@sts.org. And then if you have any general questions regarding participation or anything like that, please reach out to us at stsdb@sts.org. And Mary, you wanted the upcoming webinars. We have our next monthly webinar April 10th, our next May webinar, our monthly April 10th, May 8th, and June 12th, all begin at 2:30 Eastern, 1:30 Central. All right. I think that is it. No, you're very welcome, Mary. So Linda, do you know when frailty will be rolled out for GTSD? No, ma'am, I have not had any updates or conversations about frailty for GTSD. I think it'll be a while. I think it goes live for adult cardiac, January 1, 25, I believe is when it's mandatory. Don't quote me on that. That's Carol's domain. But I have not had any discussions with surgeon leadership yet as to when it would be implemented into GTSD. So I don't expect it, within the next 6 months or anything like that. So I think it'll be, a little bit later rather than sooner. The next webinar is on the 27th. No, so that webinar will be, that user group call will be canceled. So that information will be coming down from the website, or they'll actually post canceled on there. But so just FYI, that's a user group call series. We'll be using those moving forward for our quality improvement webinar series, which we'll have more information about coming soon. Carol and I are working out a plan for STS quality improvement project for the general thoracic database. So again, more information about that will be coming soon. But those user group calls on the 27th will not happen. But again, more information about the quality improvement series coming soon. So for now, we're just moving forward with our monthly webinars until you hear otherwise about the quality improvement series. All right, you're welcome. All right, I think that is it for today. Again, if you have any other questions, please feel free to reach out to me directly. You can reach me via email. That's the quickest way. So with that, Ruth, thank you for an amazing presentation today. That was awesome. So we look forward to our next one on some more PFT guidance. So thank you so much. Thanks everybody for joining today. And if you have any questions, just reach out.